All right. Good afternoon and hello, everyone. Welcome to today's event in our National COVID Learning Series, Securing Your Path Forward webinar, sponsored by the National Association of Community Health Centers. My name is Elizabeth Breidenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event along with my division colleagues, Cheryl Modica, Director of the Quality Center, as well as Luke Ertl, the Program Manager of the Quality Center. Before we get started, I would like to review a few housekeeping announcements. You have joined this online event by either physically calling in or using computer audio. All attendee lines have been muted and will be muted for the duration of this event. The duration of this event is approximately 60 minutes, including introductions, presentations, and Q&A. Again, the duration of today's event is approximately 60 minutes, including introductions, presentations, and Q&A. During today's session, there will be two ways that you can pose questions, comments, or concerns to us. The first method, which is the primary method we do request from you, is the chat box. The chat box is located in the lower right-hand side of your computer screen. This chat box will be available at any time for you to pose, again, those comments, questions, and concerns. Type your questions into this chat box. Please submit to either all attendees or everyone, and make sure you hit the submit button on your keyboard. Again, type your questions, comments, or concerns at any time for the duration of this event. Make sure you choose either to the everyone or all attendees section and hit submit on your keyboard. We will answer primarily most of the questions at today's event, so again, we do encourage you at any time for the duration of this event to pose those questions. We will also have an opportunity to actually unmute folks' lines throughout today's event, primarily, again, towards the end of today's event. So if you'd like to pose that question verbally for our lovely panelists, the raise my hand function will be available. It looks like a little icon close to where the attendee list is within WebEx. Just click that. We will receive on our end an indication that you'd like your line to be unmuted, and we will give you that alert once your line is unmuted. Friendly reminders that today's event is being recorded and will be available on the MyNAC website once today's event has been completed. All attendee lines have been muted and will be muted for the duration of this event. The chat box will be available. Please type your comments, questions, or concerns into this chat box at any time for the duration of this event. And then after today's event is completed, you will be invited to complete a brief 4-question survey. This survey lets us know how we did, how valuable this event was to you, and it directly informs us of future training and technical assistance. At this time, I'm going to turn things over to Cheryl, who will be moderating and taking it from here. Cheryl?
Great. Thank you, Liz. Welcome and good day. And this is the second in a 3-part series focused on building health center capacity to respond to COVID-19. This series is made possible through funding from the Centers for Disease Control and Prevention as part of NAC's COVID-19 related support and efforts. Similar to webinar number 1, if you were able to join us last month, today's session will explore 3 topic areas, all of which focus on improved business operations and response to COVID-19, but, and very importantly, are topics and strategies that can be applied to other clinical conditions and business operations. The 3 topics we will cover in this series includes, and you can see those on your screen, business continuity planning, data and informatics, and promising practice models during the COVID-19 response. Each of the webinars in the series is designed to, I'm going to go back 1 slide so you can see the full series. So each is designed to build on one another, adding content and depth over time, yet each stands on its own in offering unique content for those who may not be able or may not choose to participate in all 3 sessions. As you can see on the screen, the date and time of our 3rd and final session is December 16th at 1 p.m. Eastern. Now, to begin our content, we'll start today's session with a focus on business continuity and the importance of business continuity planning to survival and sustainability during COVID-19 and other emergencies. This portion of our program is led by Jerveen Williams, Director of Finance Training and Technical Assistance with NAC. Welcome, Jerveen.
Thank you so much, Cheryl, and thanks everyone for joining the call today. So let's just jump right into it. Next slide. So this is another highlight on the business continuity curriculum that we're building here at NAC for health centers across the country. And this slide is very telling. This is up-to-date information based on the pandemic on why business continuity is very important. The studies show that, and estimated, if you have unplanned downtime, it could cost you, and this isn't health center specific, but just companies in general, $17,000 per minute at a high end, and at a low estimate, $926 per minute. And I think the one stat on here that's very telling is that 40 to 60% of small businesses, which health centers pretty much fall into that, and if they lose that operational system without a disaster recovery plan, they could pretty much go out of business. Now, and I know right now health centers have been definitely helped with some of the provider relief funds that HHS has sent out, but without those funds, it's kind of scary to think about how many health centers would not have been able to maintain and keep their doors open based on the COVID-19 impact of the day-to-day operation. Next slide. So another important is the community impact. I know a lot of health centers had to either close certain sites or change their services and everything. So if you don't have something in place, how are you going to communicate to the community, communicate to your patients in your community that you're still here, but you're serving the patients in a different capacity, and making sure that community needs are met. And then also the staffing implications. It's like letting your staff know, like, if something happens, this is how we're going to communicate. This is how we're going to pivot and adjust based on what's going on in our community, in our health center, in our environment. So just communicating with externally and internally, having a business continuity plan will have something in place so that you won't lose contact with those key stakeholders in your business. Next slide. So with all that said, it's really important to have your board involved and know what's your plan for your organization. They need to understand the importance of it and how it's going to help you guys be sustainable, and make sure that it's a priority. Because if you don't have leadership buy-in, it's not a priority. It's not going to be a very active and robust plan to help you continue operation. And then you have to make sure that the board's holding the leadership accountable to make sure that it's tested annually, that it's updated, and that it's a live document. And then also receive regular reports on what you're doing, how you're responding, how you're making sure that that's planned. And then also, and this is the last point, is very key, if you don't have the resources and the budget allocated for this, it's not going to be successful. So it's the board's responsibility to make sure that you have those resources in the budget and in your strategic plan to make sure that it is a priority and you can be successful in building a business continuity plan. Next slide. So we talked about the board. So the board sits at the very high level, but then you need an actual team. And the business continuity team is an interdisciplinary team. It doesn't necessarily have to be the C-suite, but it has to be a team built together to see all the different aspects of your organization. Because you really want a very good diverse team, because everyone looks at things differently. So you want diverse people at the table so that you can look at the whole impact of your organization. And then making sure that the senior leadership are supporting this business continuity team and giving them the authority in order to act and respond and to educate the whole team on your whole business continuity plan and recovery aspects. Next slide. So what are the key components of a business continuity plan? I'll just go over this on a high level, but these are some of the key components. The first one is an executive summary. This is where your leadership and your business continuity team will say, okay, this is our summary, this is our plan in order to make sure that if we're impacted, we can recover and continue to do business, as a community health center. So that's a start. Then you have your business continuity team, and that's a multidisciplinary team that you're going to have in order to keep this plan going, update it, and then, if needed, implement this plan. Then you have your hazard and vulnerability analysis. So what this is an event-focused analysis. This is a systematic approach to identify and assess and prioritize potential hazardous things that can happen. For instance, obviously the pandemic or a hurricane or earthquake, or depending on where you are in the country, whatever hazard or vulnerability is you can have at your health center. So if you are in the Midwest, you're not going to have a hurricane on your HVA plan. But if you're in Louisiana, Texas, and the Florida areas, obviously you're going to have a hurricane and your hazard vulnerability analysis. Then next we're going to go into your business impact analysis. Now this is a process focus. This is assessing an organization's financial and non-financial exposure to a sudden loss of critical business functions, for example, patient visits. So this is just going through and identifying and prioritizing, and then saying, so you can do a mitigation strategy, which is the next one. So after you assess your vulnerability and the business impact analysis, then you're going to have mitigation strategies. So this is saying, based on these different analyses, what can we do to lower the impact of these different disruptions in our operations? And then next we have the recovery. So once the operations are disrupted, how are you going to recover and get back to, I'll use that word that we've all heard the last 8 months, the new normal. And then lastly, you have to plan and have drills and keep this a live document. If you put a plan together and you put it on a shelf and people aren't continually educated on it, when the emergency happens, they're not going to be up to speed. So that's why it's very important that you plan and have drills and practice on this. Next slide. So here's where you go in. You get buy-in from the leadership, board of directors, and all the staff, and also the vendors, because depending on the situation, you might need additional supplies and services and everything. So make sure you have that relationship with everyone to be on board. Then you build your team. As I mentioned earlier, it should be a interdiscipline team. So looking at all these different representatives from medical, HIT, finance, behavioral health, administration, facilities, and human resources. So looking at your team and making sure that you're covering all those different components. And then complete your business impact analysis, identify and create a mitigation and recovery strategies, and of course, training, and testing and revising as needed. So right now, everyone had to turn on a dime for the COVID-19 response. Are you guys going through and saying, okay, we didn't plan on this, but let's assess what we did well, what we didn't do well, and how we can improve on that. Because as we all know, we're going into the second wave, the flu season, and the cases are increasing. So this would be a good time for you to assess what you did well or what you had challenges of in March and April of this year and how you can improve on that.
Javine, we may have lost your audio.
Okay. Can you guys, Liz, can you hear me?
Yeah.
Yeah, I can, Javine. You sound fine.
Oh, we may have lost you. So I'm going to, because we're in our last minute of talking about business continuity planning, so I'm going to jump in and share just a couple slides here. There's two quick slides to introduce what's coming down the pipe. And in January of 2021, there'll be something called the Institute.
Okay, sorry. Can you hear me, Cheryl?
We do. We have about a minute to wrap up the discussion and introduction of the Institute. So if you want to take over for that.
Okay, sorry about that. I lost my audio connection. But so this is just some of the pieces of the Business Continuity Institute that we're going to kick off in January. So it's going to be a deep dive on all these different areas with tools and templates to help you guys build that plan. And with that, I'll turn it over to Cheryl. Thanks so much for you guys.
Great. Thank you, Jervine. So as you can see, that talks a little bit about the Institute and what Jervine mentioned, both her email addresses here, and feel free to also put some comments in the chat box or questions in the chat box that she can answer even potentially while the webinar continues on. So with that, we're going to transition from this thinking of business strategy and business continuity planning now to data and informatics, and developing data strategies, enhancing data collection and informatics systems, and then very importantly, using data and dashboards to drive quality. So for this portion of our program, I'm going to turn the floor over to Dr. Julia Skapik, Medical Director of Informatics with NAC. Julia.
Thank you so much, Cheryl. And we're very pleased today to talk a little bit more about our data dictionary approach and how that fits into our human-centered design framework, and then have one of our partners from the COVID-19 project with CDC tell us a little bit about what they're doing at the HCCN level for dashboarding and helping their FTHC partners to track and respond to the pandemic. So many thanks to Jamie Bubb from Alliance Chicago, who's going to take over in just a few minutes here. Next slide. So some of you may have seen one or both sides of the slide before. So the left-hand side of the slide depicts our human-centered design framework sort of initial phase. And in the initial phase of our HCD approach, we talk about sort of what are our goals, what are the limitations that we're trying to overcome as part of our project, what are the outcomes that we'd like to see. So we already have sort of defined a shared approach, so we make sure everyone participating gets something out of the project that's meaningful to them. Then we create some personas. We tell the story both from the person perspective and also from the use case perspective. We talked a little bit last time about our use case includes the scope that's this bubble on the right-hand side of the screen, moving all the way from surveillance and screening through treatment and case reporting. Today we're going to talk mostly about number 3, defining your data dictionary and understand what we're improving and measuring. And usually we would move after that to creating an implementation plan or an approach to improvement. So let's go to the next slide. So one of the things that we have to decide as we're developing our data dictionary are what are the things we want to measure. And we have to do that because if you've ever done sort of a quality improvement activity before where you didn't focus on the metrics at the beginning, what you'll find is, oh, well, now we can't interpret our data because we don't know if the data is accurate, i.e. if the gaps or limitations of the data are limitations of the data or limitations of what we're doing clinically or in the clinic. So these are some of the things that we're measuring in our COVID-19 multi-state project, looking at rates and patterns of COVID infection, trying to understand what the outcomes are for COVID-19 patients, specifically how many of them end up hospitalized, how long do they require follow-up visits, are there patient deaths even, how the FTHCs are responding to SDOH in the context of the pandemic. We know many of you have gone above and beyond to do things like help patients stay in quarantine by sending food and medicine to their house. We're also looking at can we predict in advance the risk of certain patients based on their social determinants, some of their clinical factors. We're looking a little bit at the impact on operations, and obviously that work goes hand in hand with Jervine's team and our policy team, who have been gathering data on this as well. Looking at changes in visit patterns, obviously there's been rapid shifts to and from telehealth over periods of time, so understanding how those service provision change from month to month. Looking at the impact of adding additional data sources, such as information from an immunization registry and HIE, and looking, of course, at immunization patterns and how people track that and to what extent there is missing data. Next slide. So this is actually a list of the major data categories from the COVID-19 data dictionary. Looking at demographics and social determinants of health, reminding everyone that we always align to existing definitions when possible to make it easiest for people to be able to extract definitions that are already there. So, of course, for FTHCs, that means looking at the UDS definitions. We also look at the USCDI definitions, United States Core Data for Interoperability, because those are required on the EHR vendor side. And then, of course, we look at prepare definitions for social determinants of health because we know those are deployed in all 50 states, and because we've worked with FTHCs on those nationwide as well. We look at both the potential for COVID-19 infections and those that are confirmed, looking at some of the comorbidities that confer risk, looking at signs and symptoms. We know actually it's a surprising number of organizations were starting to track things like fever and cough really early on in the pandemic, and that's helped to inform their health centers' understanding of where the pandemic's going. Looking at lab tests, of course, immunizations, as I mentioned, and encounters of all types. Next slide. So this is a couple screenshots from our SciMedical tool, which is a clinical architecture corporate terminology service. We basically put all of our variables into this system, and then this system allows you to provide not only what the definitions are, but also the codes and value sets that are linked to each one. This is a series of the items around testing. And if you go to the next slide, what we're gradually moving towards is not only having individual elements, but putting those elements together into a little data model that can give us much richer information. So, for example, we want to, of course, know when people have a confirmed diagnosis of COVID-19 as indicated by an ICD-10 code, but also we'd like to know what the date of that diagnosis is, whether or not there was an inpatient encounter associated with it. And when the patient resolves, if that gets entered into the system, then we'll know not just that the patient had a case, but when it started and when it finished. Next slide. So these are barriers identified by our partners in the HCCN and PCA space as part of this project. They identified these at the very first meeting, I think, that we convened them on as challenges to their success in being able to sort of perform analytics, provide feedback to their partners. Some of those challenges are related to interoperability. Can they find and identify the same patient across data sets? Can they pull in data from other sources? Can they send out data when they're required to, for example, for public health reporting? And then some of them are more technical in terms of can they pull in the claims data in a timely fashion? Does their EHR support the kind of coding they want? We know some people can get pharmacy and lab data, but they don't have the specific codes, so they don't know exactly what test is done. Some categories of data people have identified as opportunities for improvement include those claims data, right? Are the patients going to the ER? Are they getting admitted? The local health department data, both sort of from a contact tracing perspective, but also from a testing and PPE kind of perspective, getting the lab and pharmacy data in a timely fashion and relatively easily. A patient identifier would, of course, be a great help to solve some of those patient matching challenges. And I love that our partners are always thinking about the impact on their workforce and on their care teams to try and continue to stay healthy themselves as they confront the pandemic. Next slide. So as always, we encourage you to engage with the NAC Informatics team. You can contact us at informatics@nac.com. And I am very pleased to hand it over now to our colleague, Jamie Bubb at Alliance Chicago.
Thanks so much, Julia, and good afternoon, everyone. Like Julia mentioned, I am Jamie Bubb with Alliance Chicago. I am our manager of HIT operations. I join you today to hopefully highlight some of the work that our team has been doing, but I'm sure some of you are doing on the ground as well in terms of being able to provide data back to your health center and to your health center teams. So one of the things before we go to the next slide, just to highlight, the tool that I'm going to be showing you today is called Power BI, and it's through Microsoft. It is a tool that many of our current health centers that work with Alliance Chicago do have their own access to, and the ones that do not, we're able to provide, similar to what I'll show you today in a PowerPoint slide format, provide that information to their teams so that they're then able to disseminate that out across their organization to be able to look at this data. So this first report that I want to highlight for the team, and it really does play well off of what Julia just talked about in terms of some of those points in the data dictionary. This is a weekly visits report. And so if you'll go to the next slide, please. This weekly visits report is one that I'm sharing on the screen. It is actually a specific health center, but I've blocked out the name just to keep that confidential. But this health center specific visit report is looking at their visit counts by week. So if we think of the weeks by the calendar year, so this is up to the current week. This is displaying, you'll see multiple kind of visuals on this report here, and that's what Power BI really has behind it. It's a very robust tool, so it can display a lot of different visuals, graphs, as well as this dashboard format that we're looking at. So this specific health center, this is allowing them to look at by the weeks of the calendar year, starting back when the pandemic hit, kind of week 1 or week 2 there. You can see the different visits that they performed. So you'll see the in-person in blue. So that's the encounters that were actually performed in-house or at the actual brick and mortar locations. And then you'll see in red, and you'll see a kind of spike as we get farther into the pandemic, where they were performing more virtual visits. Obviously, depending on the health center, the levels and the numbers are going to change, but this specific health center did kind of spike and start to see more patients virtually over weeks 12 and moving forward. So this kind of gives you a really good breakdown of what are those different visits in person versus virtual. The graph towards the middle right gives you kind of a virtual visit distribution. So how many visits were they performing virtually that were more of those E&M visits, those primary type care visits? How many were mental health visits? You can see those in blue, and then those that were telephonic. And how we define these, I'll show you a slide quickly here in a minute on what we determined to pull into this report in terms of the mapping, but these are all based on the encounters, again, whether they were in person or virtual. And those are really driven off of the CPT codes or orders within the actual EMR. And then you'll see at the bottom, we also were able to highlight for the sites because it's as equally important for them to make sure they're staying on target for UDS. So you'll see the UDS visits broken down again by week on the bottom left with all the different specialties. The specialties are really based on how the health center has their EMR set up to say this is considered a medical visit, this is considered a mental health visit, and so on. So we really wanted to make sure that we were displaying that data to them as well, because that obviously speaks to multiple departments, billing, operations, the clinical teams, to make sure they're really hitting those UDS measures appropriately, and if they need to make any adjustments in their EMR, they can do so. So we'll go next slide, please. So that first slide that we saw was really the virtual visits or the in-person visits by week. This gives them a snapshot by month. So this is just to kind of give you and the health center kind of a better view. If they didn't want to look at it by week, it gives them really that, again, visit count, including the virtual visits by month. So just a different way of looking at the data. Next slide, please. This is, as I mentioned, we talked about the UDS kind of bucket that was on that first slide. This is just a breakdown and gives the health center really that guidance to say, do we need to work together with our billing department and our clinical teams to make sure that our UDS visits are properly marked and properly set up in the system, in the EMR? And so this gives them that data so they can make any adjustments. Next slide, please. And again, this is just kind of highlighting some of those, what we call CPT codes in our current EMR, any order codes that were included in those first couple slides that showed the encounters, virtual and in person. And these are just the different codes that were, some of the codes that were highlighted in that first screen to show you how we've mapped some of those encounters in the background to say this is an in-person versus this is a virtual visit. Next slide, please. Is equally exciting. This is the second report that we've been able to provide out to our health centers. And again, some of them have access to this Power BI tool themselves, but this is really more about the actual COVID testing. So if you could go to the next slide, please. So this is, again, this same specific health center, we blocked the name out, but you can tell they're a health center located in New York, probably one of the main hubs for this pandemic. And so this is really displaying for the health center the total number of patients that were tested, and not just the test order itself, but these are actually showing the results. So anytime the patient had an actual COVID result come into the EMR in terms of that specific data point, this is displaying those COVID patients. So you'll see on the upper left the total number of patients that had something in that discrete field for the COVID test, and then you see the list of patients negative and positive. This really gives the health center the power to recognize their patients that are being tested. Do they have any gaps in that number? So maybe they need to make sure that they're manually recording some of those results for patients that are not actually getting tested at that health center. And they can also really slice and dice this data. So obviously you'll see in the middle the map and kind of the geographical display of where these patients are located. That's based on their registration information or demographic information in the EMR. They can also look at the bottom, kind of what is the result for their patients. Starting back in October, this is just a small snapshot of the data through November. You can see, though, where some of the spikes, if you will, in the positivity rate are happening across that specific graph. So it really does give them the power to kind of go back to their clinical teams and show them this data, work with the health center to make sure they've got the right data, and again, really slice and dice this as they will. Next slide, please. And then the last slide that I'm sharing with you today is just to show you, and many of you are familiar with this because I think many of you are reporting this to HRSA, but this is just showing the patients that were tested for COVID, the breakdown of their demographics. So again, this is showing based on their registration or demographic information, their gender, age, race, insurance, poverty level, and ethnicity. And then again, if the health center wanted to slice this data a little bit, they could say, okay, let me look at the positive patients specifically. What is their demographic breakdown and what are their different demographics based on the positive patients and vice versa. So wanted to share this information with you today. I hope that was helpful, and I will hand it over to Cheryl and the next speaker. Thank you so much for having me.
Great. Thank you, Jamie. And again, for any of you on the line, feel free to be typing in any questions you have at this point, and we'll circle back to them after our last section. So we're going to turn in this final section to hear from a health center regarding its response to the pandemic and the lessons learned that can be applied not only to current COVID crisis, but certainly other emergencies. But before we turn to our health center presenters, we did want to draw your attention to a resource that we shared on our first call. This is available through the National Health Center Resource Clearinghouse, and you can see the link here. And it's also available on NACHC's website. And this document is a compilation of promising practices that we received from health centers, particularly those activities early on in the COVID pandemic. And it was submissions from over 6 dozen health centers across the country, and really represents and speaks to the breadth and depth of change and transformation that all of you across the health center field have been engaged in the many months since the start of the pandemic. And so in this document, you'll find both contact information for particular health centers. You'll also find links that take you to tools and resources and templates that health centers shared. So again, we encourage you to take a look at that resource when you have a chance. And today, we're going to feature one document or one submission in that larger compilation, and that's a promising practice from Denver Health Services and their work in shifting from telehealth as a quote-unquote acceptable substitution to, very importantly, a meaningful standard of care. And so for this presentation, we're joined by 2 members of the health center team. One is Dr. Lara Penny, a family physician and currently medical director of the Montbello Family Health Center within Denver Health Services system. She's been a health center provider for 20 years and has a passion for developing innovative ways to deliver high-quality, patient-centered care that's not only efficient, but maximizes the joy of practice for providers. We're also joined today by Dr. Thomas Staff, who was trained and did his residency in family medicine and a maternal and child health fellowship and MPH in Chicago, working there in a health center until transitioning in 2012 to the Denver area, where he now serves as Associate Program Director with the University of Colorado's Family Medicine Residency in the Denver Health Track. And so with that, I'm going to turn it over to Drs. Penny and Staff.
Hello, good morning and good afternoon. Dr. Penny and I are here from Denver and wanted to give you a brief bit of background. So our FQHC is part of a vertically integrated and a pretty large network here in the city and county of Denver. Denver Health and Hospital Authority is the larger organization. It includes a hospital as well as a network of systems, including public health in the city of Denver, and many things you can see on here. Next slide. But our FQHC is, we have 9 sites that provide primary care and also 18 school-based sites. We have a general primary care model with family medicine, general internal medicine, pediatrics, women's care with OBGYN and midwives, as well as services I didn't list would be dental, integrated behavioral health, MAT, et cetera. But for the purposes of this, we wanted to just explain going from our fairly typical model of outpatient care, seeing approximately 11 visits in a half-day session, caring for about 150,000 patients annually, and then how we transitioned during the pandemic. Next slide, please. So the timeline is no surprise to any of you. In March, when we really felt the first surge, we had a dramatic decline in in-person clinic visit demand. We obviously felt the increased need for safety for our patients and staff. There were concerns about PPE supply, financial pressures with these changes, and a tremendous opportunity to change the model of care that basically in terms of what was in front of us at the moment and what we could see was coming from this rapid change. By June, we noticed, again, a leveling off of that initial surge of cases, and then, of course, here we are in another big surge of cases with all of you. Implementing telehealth during this time, back in March, really, as many of you felt, was building the airplane in flight. But acting quickly, we have a model that's adaptable, and we were able to apply it, as needed for the patients that needed care and were seeking it, as well as applying it to outreach for recommended screening that was also in our patient panel. Of course, this was made possible because it was reimbursable too, and we began our venture into this with telephone-only telehealth. We had to sort of think about this in terms of how can we provide care, how can we teach our learners in providing care, how can we use translator and interpreter services for providing care. This was done, again, quickly, but we sort of would reevaluate and refine the model as we went. And by the summer, as the curve flattened, we noticed that our in-person demand began to come back. We decided to continue the telehealth model of care, and we wanted to do this to maintain physical distancing still in our office space, in our waiting rooms, to make this safe for our patients and for our employees. And the model roughly broke out to about 2/3 being in-person care and 1/3 being telehealth in terms of our model. Dr. Penny, did you want to talk a little bit about your experience here in terms of making this transition from that initial surge to the summer model?
Sure. So what we noticed in June is, we got a little bit of breathing room, but we also realized the potential for telehealth. I think early on it was just chaos a little bit, right? See as many, attend to as many patients as we can. A lot of continuity kind of fell by the wayside. Once we had a little time, it was we think telehealth is good for patients, we think it's good for providers, and we think we can achieve the QI that we strive to achieve, right? But how can I prove this, and what do I need to do to show this? In my specific health center, we have, in my 14 years, never been able to meet the demand in our community, so we have huge access issues anyway. And then our physical layout is such that I couldn't bring everybody back in person because we weren't able to socially distance. So I really had to keep a percentage of telehealth visits, period. So basically what we looked at was putting a sort of in various ways. So I assigned one provider to do only telehealth for a 3-month period, and then I had other providers doing a mix. And I based it on, and what I wanted to look at is patient satisfaction, provider satisfaction, QI, and and visits, right? So is this sustainable business-wise? And so basically what we did was we sent out a survey to providers around telehealth in general with the suspicion that telehealth was a pleaser. So we did that. Meanwhile, because we're part of a large organization, our patient satisfaction surveys, they quickly adapted those to be able to query telehealth patients. So we were able to get that data. And then as an NACHC, we're tracking all the QI stuff that we have to submit and then some. And so that was easy enough to be able to report on. So again, this is getting to that quadruple aim. Can we make patients happy? Can we achieve the quality that we want to achieve? Can we take care of our providers who at Denver Health and in FQHC systems are just as burned out as everywhere else? And can we be cost neutral, basically, or even be better than cost neutral? Yeah,
that's right. And so within just the first couple of months, we did use this quadruple aim framework. And just as Dr. Penny was saying, we wanted to make sure that we were doing the right thing, and knowing that it was one of the few things that we really knew that we could do at this time. And so it fit well that the patient experience was good by the measures that we had, and even in our more vulnerable groups, we have large populations of refugee or former refugee patients and immigrants, and using our navigator staff, when we got people accustomed to the idea of telehealth, they started to really appreciate that they could communicate with the medical team, they could get help and services without needing to coordinate transportation, without having to take up much more time from work or coordinate childcare. With our medical assistants that were freed up when we had providers working remotely, they could be tasked to working lists of recommended screening and some of the quality improvement initiatives that we were working on to address some of the population health concerns. Like Dr. Penny was saying too, with the cost efficiencies is, you're not limited by number of exam rooms. And frankly, getting this model to spread out our staff and to sort of decompress sometimes very crowded or very busy clinics was a tremendous advantage. And then next slide. And then, what we found is that we have a large medical staff, and we feel that our mission, just like all of you, is a noble one. And yet our percentages of providers reporting some burnout was at the national average, that despite having meaningful work, we still had this same level. In the midst of the pandemic, with all the uncertainty and all the rapid change, this transition to the telehealth model was tremendously impactful. On our family physician medical staff alone, which is about 100 providers, 61% reported decreased symptoms of burnout, and 81% reported that they had improved work-life balance, just the ability to have some portion of their regular work include telehealth. So this was, as we look for ways to address the joy in practice, to address burnout, this was incredibly impactful. Next slide, please. Additionally, within our system, our FQHC, our primary care workforce, was also working with the hospital, and we had a few other initiatives that also increased the amount of work we were doing remotely. We had an initiative called Virtual Hospital at Home, and also medical home monitoring. And both of these were ways to care or check on patients, care for patients who were diagnosed with COVID, were sent home because they didn't require hospitalization, but did require frequent monitoring, especially early on as we were learning about the course of this disease, and also just watching people at risk for deterioration. They were sent home with blood pressure cuffs, pulse oximeters, and sometimes thermometers, and then we would have a nurse and a provider check on them daily. The rollout of video visits has been slower. We started with specialty clinics, and we're gradually rolling that out in primary care. Of course, specialties like dermatology lend themselves to this a little bit better, or obviously needed a little bit more than would be appropriate for telephone visits. And obviously, we're tackling some of the requirements here, the technology needed in the clinics and the technology that the patients need, and the understanding of how to connect these, and watching the reimbursement implications here too. Next slide, please. But then, again, Dr. Penny sort of was instrumental as we looked at this in the beginning and thought about how is telehealth valuable for one busy site, and then how can it be valuable for the whole organization. And so, as I mentioned before, with 9 primary care clinics in our system, as the surge comes back, can we do anything in a more central way? And so, Laura, do you want to sort of talk about and how we pivoted to this model here?
Sure. I think the exciting thing about telehealth is the flexibility that it provides us. And so, I feel like when our demand was lower and we could do a bunch of planned care through telehealth, that was fantastic, and we showed that we can achieve QI. And now here we are in the midst of quite the surge, and our system has about a 25% positive rate with our testing. And in general, and at the same time, people have finally decided that the clinics are not scary and they want to come in and get all of their deferred primary care. And in general, in our system, the family medicine clinics are completely overwhelmed, and the pediatric clinics much less so. And so basically what I looked at was how do we, what services can we sort of divert to people who are being underutilized? And the most obvious was basically getting people tested, right? So getting people tested for COVID, getting people consults for COVID results when they're positive, sometimes when they're negative. For anyone doing this work, they understand the complexity of these encounters. I'm not sure if some states have really good contact tracing. We are not one of them because of our surge. And so basically what we have done is created a telehealth team that is staffed by providers that are being underutilized. So right now in Colorado, most of our schools, certainly in Denver, are remote learning, and so the school-based clinics that are part of our system are really not very busy at all. And so we have taken school-based providers who can now man this telehealth sort of virtual clinic, and we can divert patients who are looking for COVID testing or who sort of smell of COVID, right? They're calling with cold symptoms. They are, to sort of siphon that off from the primary care site so that we can continue to do our regular primary care and not gum up our templates completely with COVID testing requests. And prior to this, what we were seeing
Penny,
is...
Penny, I'm going to stop you there because just in the interest of time, we want to leave some room for some questions. And I think you just outlined, and Dr. Sheff as well, some tremendous work that Denver Health is doing on many aspects. I have your last slide up, with just shows how you're continuing to adapt your staffing models. Thinking about the vaccine administration, which we have one slide for those of you still on the line. We'll show in a minute for you to keep in mind as we get to the point where we have some vaccines soon coming out in the field, or at least available at some level across the nation. So again, thank you for your comments today, and really for all our presenters. And I'm going to turn it over to my colleague, Luke Ertl. I think we've had some great questions coming in the chat box, some of which Jamie and others have been answering in real time. Luke, any questions at this point for us still to bring live, or hands raised? And I'll remind folks, you can raise your hand to ask some questions, and we'll unmute your line.
Sure. Thank you, Cheryl. So I want to go ahead and repeat a couple of the questions that Jamie had been answering in the chat box, just in case some other people had the same questions and didn't see those, what was coming through. But Jamie, could you talk a little bit more about, there were some questions about being able to see or present the COVID test positive rates by population and, population of the clinic. Also interest, or there's also some interest in rates per race and ethnicity and medical comorbidities. Could you speak a little bit about that and flesh out some of the things that you had mentioned in the chat box?
Sure. Yeah, and I know for our Alliance Chicago data team, the information that I shared with you today on the slides, that's kind of the current report, but absolutely any other kind of discrete data from your EMR, whether those are ICD-10 codes or other items that you'd like to add into that type of report, those are absolutely available. Again, especially if you have those as discrete values in your EMR. So if you're looking at a specific patient population and you want to see their positivity rate, for example, that would be an option through Power BI. And I think some other questions were coming in just in terms of how people can access that. So the easiest way, and this is something that our health centers have done, is if you already have an existing internal Microsoft 365 account, you can get a Power BI account through Microsoft that way. And as I understand it, even currently, there is a discount of, it's about less than $10 a month for any of your users at your health center that would make sense to have that kind of access. And our health centers who have their own access then really do have hands-on, access to their data to be able to slice and dice it, add in those fields that you talked about and asked about, Suzanne, in the chat, to kind of look at specific patient populations or by comorbidities. So I hope that answered those questions, but I'm happy to answer anything else if that wasn't clarified.
Thank you very much, Jamie. If there's any additional clarification that anybody would like, you can go ahead and plug that into the chat box or raise your hand. Or if you have any other questions, feel free to put those in the chat box or raise your hand. We had one other question come through real quick for Denver Health. How have you been able to address patients with digital divide barriers?
This is Laura. I would say, we are doing 99.9% telephone visits, and so it hasn't been the same issue for us. It will be if we are sort of forced from a reimbursement perspective to do video visits, but for now, within primary care, we are mostly doing phone and are very slowly ramping up video visits. So I think we have yet to experience the joy of that divide.
Thank you, Laura. That is all the questions for right now, Cheryl. So if you have anything else that you'd want to add in, and again, if you have any other questions, please add them into the chat box.
Great. Thank you, Luke. So again, we'll give you another moment for any additional questions, but we do want to have or take just a moment, since this is a series focused around COVID-19, and so want to be sure that all folks on the line are aware of the COVID-19 vaccination program. Again, we often get questions here at NAC about when will the vaccine be coming out, and certainly I think we are hearing information but don't have specifics around that. So we do want to say that the best place for you to be connecting to, you can see the reference on the bottom of this slide from the CDC. This is the COVID-19 vaccination program. There's an interim playbook. They are continually updating this playbook. The version you'll see here is version 2, dated October 29th. But very importantly, that you as health centers know, and again, if you're PCAs or networks, you probably are connected into this, is that health centers must complete what's called a vaccination provider enrollment. It's an application process in order to receive COVID-19. So again, regardless of when the vaccine becomes available publicly and wherever health centers will end up falling in the continuum of distribution, in order for health centers to receive that vaccine, you must submit an application. And as you can see here, what that really means is through your jurisdiction. So typically that is your health department. Again, there's some additional guidance around being credentialed and licensed in that jurisdiction. But if you have not already been in touch with your health department about that application, we encourage you to do that outreach, as there are various local sort of state or jurisdictional applications that are being developed for specific health centers to complete. And then a final slide to remind you or share with you again the date of our last session, kind of looking over the horizon or looking forward, and that session is December 16th at 1 p.m. Eastern. And as you can see, there's some information here that you can go to if you haven't yet registered. And with that, I think that brings us just 2 minutes to the top of the hour. Liz, I'll turn it back to you for any closing comments and closing us out today. And Liz, you may be on mute, so I'll also ask maybe Luke if we close out with any comments or questions. If there's anything yet unaddressed, then we can be sure to include that as a follow-up. Please also note that there is both each of the participants provided email addresses or contact for the most part throughout the course of the presentation. If for any reason any of your questions did not get addressed, feel free to reach out to me and I will put you in touch with the presenter, and we'll make sure that we get your questions answered. Luke, any final comments or guidance in closing out today? I think we have a couple of evaluation questions.
Yep, I'm going to go ahead and put in in the chat box a link for you to go ahead and fill out the evaluation questions. Your feedback is important to our webinar series and all of our other training technical assistants for NAC. And also we got some requests for the link to the resource, the compendium of all the best and promising practices for during COVID-19. So I'll go ahead and drop that in the chat box. With that, we thank you all for joining today. Have a great day.